So you can see my topic has pharmacologic approaches in the title, which is one topic that we will not talk about at this conference except for the next 15 minutes. I forgot to put in the disclosure slide, so my only disclosures are funding from the NIH, VA, and PCORI, no pharma industry or other financial conflicts of interest. This is my approach, and I think it should be basically balanced. I think this session has been imbalanced. It's been towards medications. I just want to make sure that we talk a little bit about the role of medications. I would say, as we found out this morning, that about all non-pharmacologic treatments are about created equal. I mean, they all have modest effect sizes, the evidence-based ones, and so basically stratification, patient preferences, all of that are going to play an important role. Same with medications. All medications have a modest effect. There is no dominant treatment. The scope of my presentation is going to be chronic and not acute pain, musculoskeletal, which is 75% of all chronic pain, empiric data, not mechanisms. Why am I going to spend most of my next 13 minutes on pharmacologic? Because the rest of the workshop you're going to hear plenty on. Historically, it's still currently, it is a common modality. And I was supposed to talk about the synergy between pharmacologic and non-pharmacologic. Well, there's limited evidence for combined modalities, which I'll show on the next slide. I tried to do a quick search prior to the meeting. I didn't use a Roger Chow approach. It was a quick search, never having looked at this topic before. And I was trying to even figure out what broad search term. So this was a very quick search. And the few articles or reviews that I found combined two non-pharmacologic or two pharmacologic, but rather than a pharmacologic and a non-pharmacologic. So we've done a few trials, but like that, which I'll show in one slide, but we didn't unbundle them. A more effective search would need to list every medication and non-pharmacological therapy by specific name and still have to determine which were combination trials. So that's probably the next ARC-funded study for Roger. So I love this slide. So JAMA, there's this global burden of disease, and there's a U.S. component which looks at years lived with disability, which means not if you die, but actually if you live with the disease, which most chronic pain do for decades. And it's the amount of disability and the prevalence in the population. So if you look at the 12 leading medical causes, which are here, these are the top 12 out of 30, years lived with disability, 8.8 million years lived with disability in the U.S. If you take 5 pain conditions, 4 of which are musculoskeletal. They are the number 1, 4, 5, and 9th leading cause of disability in the U.S. They count for more disability than the top 12 medical causes. If you add depression and anxiety to it, which is comorbid in 30 to 50% of people with chronic pain, your response should be, wow, why aren't these getting more funding and attention? You've heard, but this is just data from 2 pain trials in primary care. Chronic pain is seldom a single site. So the problem, if you only study back pain, you're going to get a lot that comes with it. So I do believe we need to find treatments that are effective across different kinds of pain sites, because even most pain patients have more than one site. So this is the analgesic ladder we've used in 5 effectiveness trials, and the references are at the bottom. And it's, number ones are the ones that are what we call the simple analgesics. They're available over the counter. Then there's the tricyclics and muscle relaxants. Then there's the gabapentinoids. Then there's the SNRIs. And then there's the opiates. And then there's the topical. In our most recent trial, what changed? Well, 2 came off, right? Even in those previous trials, opiates were always a last resort. But 1/3 of the patients, and these were all VA studies, came in on opiates already. That just shows the issue of chronic pain in the population. And we didn't discontinue opiates, but we only seldom started it. But in the recent trials, it was basically verboten, just because of the nature. So it's now, this is not a complex analgesic ladder. Most people who take care of hypertension and diabetes have a ladder. And by the way, most of the treatments have about equal effect in that ladder. They're chosen for other reasons. So pain is not that different from hypertension or diabetes or depression for that matter. Roger Chow didn't have time to talk about his pharmacologic review, which was focused on back pain and published just a year or 2 ago. The only effective ones from trials, and 3 have had a lot of evidence, are NSAIDs, opiates, but opiates are there, a lot of trials. And muscle relaxants don't count because it's small effect in acute low back pain. I'm only talking about chronic. okay, and 3 trials on duloxetine. Everything else on the list, no effect. So I'm just going to have a couple of slides talking about a couple common treatments pharmacologically. What about NSAIDs? I mean, that's sort of the thing out there. I mean, that's the over-the-counter, other than acetaminophen. I mean, those are the 2 pills available over-the-counter. Osteoarthritis, it's a benefit versus balancing act. Slightly better than acetaminophen, and acetaminophen's effect in osteoarthritis is small. One type of NSAID not superior to another, and there's been some warnings about in people with known CV, particularly cardiovascular disease, or 2 cardiovascular risks. Low back pain, probably only a small effect, 13 trials, 6 placebo-controlled. Small benefit, so Roger kept mentioning this morning, you know, a 1-point change on a 10-point scale. If you use a 100-point scale, it's a 10-point change. So is a small effect. So 3.3 points, okay, small effect. All trials were short-term, NSAID adverse events not greater than placebo. So the NSAID story has a role in osteoarthritis, probably a small role in low back pain. What about opiates? Okay, this is my single opiate slide, but there's been 13 RCTs studied short-term effects, 10 points on a 0 to 100 scale. 6 RCTs studied intermediate effects, 3 to 12 months, 8 points on a 0 to 100 point scale. No RCTs examined long-term effects. Interestingly, most pain treatments have not studied long-term effects. So you just can't beat up on a particular pharmacologic agent. The nature of funding does not desire, you know, studies for years. No RCTs examining acute back pain, so the dropout is higher. So take-home point, and Aaron Krebs' recent SCOPE trial in JAMA showed if you compare non-opiate to opiate analgesics in a structured care management way where you're optimizing treatment, which doesn't happen in primary care, by the way, you got good benefits. You got modest benefits from both opiates and non-opiates. They were equal benefits, so it's not like non-opiates are better, equal analgesia. Higher side effect rates in opiates, and so that's a pretty consistent finding. What about our favorite? You know, take acetaminophen. Well, for you know, that's so meta-analysis of 13 trials in OA and 10 in the knee, 3 in low back. No, 13 trials in OA of knee, hip. There were and might have been, yeah, and 3 low back pain. They used the 0 to 100 scale. Low back pain, no significant effect compared to placebo. OA, 4 points. So we seem to be consistent. This, like Roger said, sometimes a half a point to a point. That's what we're seeing for pharma. Half a point, 4 points to 10 points on a 100-point scale. Small effects, okay? Similar to many non-pharmacologic treatments. Gabapentinoids, only indicated for neuropathic pain. The more recent one, pregabalin, also for fibromyalgia. They are evidence-based, but not for back pain. Only a small number of studies. Bottom line is negative, okay? So got to have a slide on cannabis, you know, the new panacea. 27 chronic pain trials, low-strength evidence that alleviates neuropathic pain. That's not most of what we see with musculoskeletal pain. Insufficient for other types of pain. Harms from 11 reviews. Now, these were largely not trials, but epidemiologic studies. Most trials were short duration. Have we heard that story before? Okay. And used synthetic FDA-approved cannabinoids rather than more complex marijuana products. So results were similar in another systematic review. So before, because there is a bandwagon effect, and I'm not against the legalization of marijuana. I'm just saying let's not over-promote its what we know about its evidence for chronic pain, because it's going to get widespread use for chronic pain. Placebo, we've heard several times. Pain responses to placebo are usually 30 to 50%. Placebo responses have a biological underpinning. It triggers endogenous neurotransmitters that act on the same receptors as synthetic opiates. Analgesic responses induced by placebo and by opiate medications are immediately largely overlapping pain circuits. However, since current practice does not condone administration of placebos, except in the trials that Lynn DeBar mentioned, where you said, hey, you're getting this placebo, it might work. It has powerful effects. We are not authorized to give sugar pills yet in practice, okay? So we try to maximize the 2/3 of any pain treatment benefit we get, which is the nonspecific effects of what the patient's expectancies are, their beliefs, the mindset, particularly our therapeutic relationship. And it's the same with pills as it is with acupuncture, that 2/3 of its effect is always placebo. In trials, it means, oh, it's only got a weak effect. But in practice, it means it has more of an effect, and we should maximize that. What are the 7, this is probably the only time you're going to hear the 7 caveats of non-pharmacologic treatment for chronic pain. Evidence standards are not as strict as for drugs. It's imperfect placebo. Roger mentioned that. It's harder to mask. Some of these actually require work. And, you know, patients have to do multiple sessions. They have to change lifestyles. They have to practice it. They have to continue to do exercise or mindfulness or cognitive behavioral strategies. Some patients are going to do it, some not. We know that's true of weight loss and exercise and other sorts of things in general. Superiority to analgesics is not established. Long-term benefits, not well established in many cases. And shortage of trained and interested providers. I think of the 2 PTs. So I saw the slide that Patricia showed of these evidence-based treatments of acupuncture, chiropractic, physical therapy, and psychologic treatments. So I'm going to call those the 2 PTs, physical therapy and psychologic treatment. Most of those practitioners are not interested in treating chronic pain. That's not what their training is. It's a difficult thing to treat. In trials, they have been. They have been pain-focused physical therapists and psychologists. But finding people out there who are going to do pain-focused CBT is different than CBT for depression or anxiety. And then variable reimbursement. Now, here's the 4 trials we've done in which we've tested a pharmacologic and a non-pharmacologic intervention. One, Bob Kearns mentioned, was a SCAM trial. Here's 3 others, all done in the VA. 2 focused on pain only, 2 focused on pain and depression. Our recent study focused on the PAD triad, pain, anxiety, and depression. Heavy component of telecare. So we combined antidepressants and self-management versus usual care. We combined an analgesic ladder and added CBT if needed compared to usual care. Optimized opiates were compared to CBT. That was Matt Baer's Cameo trial. And in a most recent trial, we compared optimized analgesics, mood treatment, and self-management to automated self-management only. Well, what did we find? It's not hard if you have a usual care arm in pain to do better. In fact, one of the interesting things we have really found in pain trials, the number of people who worsen. We think pain is a chronic disease. We don't think of it as a deteriorating disease. When we ask a global question over 3 to 12 months, at the end of 12 months, 1/3 of people in the usual care arm with chronic pain have worsened. Okay, so maybe this is like multiple sclerosis. I don't know. It's a pain condition. They worsen, and only 1/6 of people in the active group worsen. So twice as many people worsen. Sometimes we don't take that into account. So are we doing harm by not offering some of these non-pharmacologic and maybe optimized analgesic treatments, which are not currently feasible in primary care because we don't have care management? The one trial, now the problem is we can't unbundle because you say, what's their synergy? Well, in 3 of the trials, we used a pharmacologic and non-pharmacologic strategy together. And somebody, maybe it was Roger, mentioned the tidier thing of a way to unbundle trials, but we have an unbundled effect. So we can't say which is the most effective. And the only one where we compared a pharmacologic to a non-pharmacologic, they were equivalent, okay? Not surprising, all of effect size is about 0.3. So they're getting close to the end. I think Dennis Turk said, because I was whining on one of our conference calls, I said, you really want me to talk about synergy between pharmacologic and non-pharmacologic? I don't know that I've seen a lot of evidence for that. So he sent me 3. They're antique. They're all from about 25 to 30 years ago. He only had access to them because he put them in a grant. Maybe it was a failed grant. I can't remember. Dennis. One good study in here. Chronic tension headache by Hallwright, 203 patients in JAMA 26 years ago, compared nortriptyline plus stress management to either one alone to placebo. The combination was marginally more effective than monotherapy, and most monotherapies were more effective than placebo. The other 2 were small fibromyalgia studies that had weaknesses in it. But not a lot of combination trials out there. What are challenges with combined modality trials? Most all pain treatments have only modest efficacy, so there's no dominant therapy. So what are you going to pick to study? There are numerous medication non-pharmacologic options. I'll show you in the next slide. If you only limit your possibilities to 6 drug classes and 6 non-pharmacologic modalities, you'd have 36 trials. If you study 4 common pain conditions, you'd have 120. If you add devices, which we're going to talk about next, even more trials. And so if you combine 6 non-pharmacologic with 6 pharmacologic, you'd have 36 possible combinations. Second to last slide, future research in combined modalities. We need to commission Roger to do a systematic review of combined modality trials, but he'll probably be even worse than the one that he said was difficult enough. Patient preferences are really important. Since they're all about equal, we really need to study what's the patient preferences, what's the optimal sequencing, which treatments are generically effective rather than across pain condition, what defines long-term effectiveness, alternative trial designs. So I'll close on a quote that we had in an editorial. Imperfect treatments do not justify therapeutic nihilism. A broad menu of partially effective treatment options maximizes the chance of achieving at least partial amelioration of chronic pain. Thank you.